Yes, hi guys, welcome for the KNO classes. This is your Nagraj, your NORCET mentor and NORCET guide. So we are dealing with the all your high yield MCQs. Okay, so we are discussing the all subject. Okay, we are covering the all subject and we are discussing the very important MCQs that are very needful for your upcoming NORCET 10 examination prelims and mains. Okay, so if you want to do a good preparation, okay, if you want to do a actual preparation, okay, so you have to do a MCQs. Okay, you have to solve the MCQs. Okay, solving the MCQs will increase your it will increase your reflex of solving the MCQs in an outside examination. Okay, so if you daily solving the MCQs, what will happen? So that will improve your skills. Okay, handling the MCQs. Okay, how we can eliminate the question. Okay, how we can use the approximate answer. Okay, so like that you can have the techniques. Okay, you will develop slowly. You will develop the skills to attempt the MCQs. Okay, means everybody will attempt the MCQs. Okay, but it's matters about the time. Okay, how much you are taking the time to solve the MCQs, how much other person is taking the time to solve the MCQs. Okay, that's decides your selection. Okay, that's decides your selection. Okay, how much accurately, how much quickly you are choosing the answer. Okay, that defines your selection. Okay, apart from all knowledge. Okay, all studies. Okay, all everything. So your MCQ reflects. It will also decides your selection. Okay, whether your the name is there in the list or not. Okay, so if you want to do actual preparation, you have to solve the MCQ. Okay, there is no any other shortcuts. Okay, how to solve the MCQs. Okay, sit and solve the MCQs. Okay, so without with this one beautiful quote. Okay, we can start with today's class. Okay, yes, you can. Okay, means the only person. Okay, you can change your family's. Okay, your family's economical status or your family's reputation in your relationship. Means okay, that person is you. Okay, you are the game changer. Okay, you are the game changer of your family. Okay, only you can able to change your family's lifestyle. Okay, your family's. Okay, your economical status. Okay, so you have to do a hard work for your family, for yourself. Okay, it is not about. Okay, it's not about the you and your friend. Okay, you and your other society. It is you versus yourself. Okay, you have to. Okay, you have to define yourselves. Okay, you have to tell yourselves to. Okay, study well. Okay, do hard work. Okay, do dedicated work. Okay, study how to study. Okay, that is okay. Yourself has to put a challenge and how to do yourself. Okay, no one is going to tell you. Okay, Nagraj, okay, go and study today. So you have to study for 2 hours, study how to take for the hours of class you have to take. Okay, nobody will take person. Okay, the person inside you. Okay, the intuition. Okay, only you can have a challenge to yourself. Okay, you will challenge yourself. Okay, daily. Today I'll study for 3 hours. Okay, tomorrow I'll study for 4 hours. Okay, day after tomorrow I'll study for 5 hours. Okay, like that you have to push your limits. Okay, keep on pushing. Okay, tell to your mind. Okay, keep on tell to your mind. So what you will tell to your mind, that mind will listen to you. Okay, so tell to your mind. Okay, I will study daily. Okay, I'll study more. Okay, I'll study a little bit 10 minutes extra today. So I'll study little bit half an hour extra today. Okay, like that you can tell to your brain. So your brain will listen. Okay, what you will tell, that will happen. Okay, so keep on telling. Okay, tell to your brain that okay, I can do it. Okay, I can do it. I can do it. I can do it. Okay, if I can do, I cannot do. Nobody cannot do it. Okay, like that you should have a mindset. Okay. So with this like motivation code. Okay, we'll go with the first question of the session. Okay, here is the question. So here we're having the which of the following is the type. Okay, is the type of the closed suction drain. Okay, so they're asking you regarding the closed suction drain example. Okay, option so one so first statement is the Penrose drain. The second one is a hemovac drain. The third one is a nasogastric drain. Fourth one is a JP, nothing but the Jackson Pratt drain. Okay, that is your JP drain. Okay, in a short form, we call that one as JP drain. Okay, option A is 1, 2, 3 are right. Option B is 2, 3, and 4 are the example for closed suction. Okay, here you can see correlate with the closed suction, and you can see third one is the 2 and 4 are the closed suction drain. Option D is the 3 and 4 are the example for closed suction drain. Okay, just see the question. Okay, just analyze the options and just try to put your answer in the comment section. Okay, just see. So they're asking you, okay, what are the examples? Okay, what are the examples for your close suction drain. Okay, so we in normally, okay, if we talk about the drains. Okay, if we talk about the drains. Okay, we're having the two type of drains. Okay, we're having the two type of drains. That is your one is open drains. Okay, open drain system, and the second one is your closed drain system. Okay, so I'll give example just here. Just can see, eurometer is an example of eurometer. Okay, eurometer, if you see, Urometer, okay, urometer is example for closed suction drain. Okay, it's example for closed drain. Okay, if we see Euro bag, okay, Euro bag, if we see Euro bag is an example for open drain. Okay, open drain. Okay, you can see here, okay, I'm having the like image of like you can see this one Penrose drain, okay, this Penrose drain, okay, especially this one is used in the superficial like was appendicitis, okay, appendicular abscess, okay, so all your abdomen wounds, okay, they will use the Penrose drain and the corrugated drains, okay, these two are the example for open drains, okay, this works on the basic principle of gravity, okay, based on the gravity, all the extracellular fluid, okay, after the surgery, okay, after abscess removal, okay, after IND, but all, okay, all serous matter, okay, all the discharge collected in the specific area of the cavity, body cavity, it will come, okay, it will come according to the gravity, okay, but gravity will pulls the all extracellular fluid, okay, into the drainage bag, okay, that is your open drains, okay, so this since it's a open drain, okay, there is a high risk, okay, high risk to like bacteria to enter, okay, so high risk to have a infection, okay, infection risk is more in the open drains, okay, if you see the like closed drains, okay, they will works on the based on the principle of gravity plus capillary action, okay, gravity plus capillary action, okay, so you can see, so T tube, okay, T tube is a like when we'll use, okay, if we know that, okay, T tube especially will use in the case of CBD exploration surgery, okay, CBD common bile duct exploration surgery, okay, they will explore the CBD common bile duct and they will place the T tube to drain the bile product. Okay, so that's what your example for your closed suction drain. Okay, and you can see a JP drain, okay, Jackson Pratt drain, Hemoic drain also considered as the example of closed suction drains. Okay, closed suction drains. Okay, it's not having any breach in the continuity, the whole drains will be intact with the body tissue, okay, inside like will be closed, okay, it will be connected to the closed drain system, okay, so this all are the example, okay, our NG tube, okay, and the Robinson trim, okay, this all are the example for closed drain, okay, but if you see this one Pratt drain and the Hemoc drain are the example of closed suction drain, okay, closed suction drain means that will have a negative pressure, okay, negative vacuums will be there, will compress, okay, will compress the hemocran, then will connect to the like drain side, then will release the pressure. So with the negative pressure, okay, with the negative suction pressure, that all extracellular fluid, okay, all the debris from the surgical site will be coming into the suction drain, okay. So that is a Jackson flat drain, Hemoic drain are the best example for your closed suction drain. Okay, but if you see your T tube, okay, your Robinson drain and your NG tube, okay, nasogastric tube, this all are considered to be a closed drain. Okay, not a closed suction drain. Okay, why I'm specifically telling you cannot put the suction for the T tube. Okay, you cannot put the suction for Robinson abdominal. Okay, you cannot put the suction for NG tube. What will happen? There will be a collapse will be there if you put the suction means. Okay, so that are considered to be a closed drain, but that are not non-suctionable drains. Okay. All of you clear regarding here the written. See, just you can see closed non-suction drains. Okay, non-suction drains. Okay, that are the example for closed but non-suction drains. Okay, all of you clear. You can see. Okay, one more. Okay, like an example for Penrose drain. Okay, this one you can see they done a surgery here. Okay, they done a surgery. So they wanted to okay take out the like all debris. Okay, extracellular fluids okay, collected after the surgery like blood and serous drainage. Okay, from the Penrose drain. Okay, this one is example for your Penrose drain. Okay, that are the example for your Penrose drain. Okay, and I can see one more drain that is your like a corrugated rubber drain. Okay, it is a corrugated rubber drain. Okay, these are the example for corrugated rubber drain. Okay, all of you clear regarding the drains. Okay, this one is the open. Okay, this both are the example for your open drains. Okay, corrugated drain and the Penrose drain. Okay, all of you clear regarding the drains. Okay, you can see now. We'll go back to the question now. I think hope so. Okay, everyone is clear regarding the open drain and the closed drains. Okay, open and closed drain. Okay, these two are the closed. Okay, closed non-suction. Okay, closed non-suction drains. Okay, you can see this one is the T tube. Okay, this one is you can see based on the shape also. It is the T tube. Okay, exactly place it in the common bile duct. Okay, this one is the gallbladder. Okay, this one is the like duodenum. Okay, and this one is your common bile duct. Okay, we'll place the common bile duct into the abdomen, okay, through the abdomen, okay, we'll make an incision in the abdomen and then through the incision we'll insert the T tube into the common bile duct, okay, when we'll do the surgery of common bile duct exploration. Okay, we call that one as CBD exploration surgeries. Okay, in a CBD exploration surgeries. Okay, in a CBD exploration surgery, especially laparotomy, will place the T tube. Okay, T tube to collect the especially to collect the bile. Okay, bile which is secreted from the liver. Okay, you can see this one is the ICD tube. Okay, this one is the ICD tube. Okay, by the brand name called as Robison. Okay, Robison is the brand name for the Robinson Rain. Okay, Robinson ICD Rain. We can say Robinson ICD Rain. Okay, so here you can see this tube, this tube part will be going inside the chest cavity. This remaining all part will be there outside the chest cavity. Okay, this one is regarding the Morrison. Okay, up to here. Okay, up to the 100 level, we have to fill with the water. Okay, we have to fill with the water. Nothing but the normal water, normal saline or the sterile water we can fill. Okay, to have the water sealage. Okay, that's regarding your closed non-suction drains. Okay, closed non-suction drains. You can see these two are the example for closed suctionable drains. Okay, means this works on the principle of vacuum or the negative pressure. Means will compress the hemovac drain, then will release the drain. Okay, so that by that negative pressure generated by the hemovac drain, so that will be all, it will collect the all fluid from the surgical site. Okay, and in Jackson pad also just will compress, then we connect to the like surgical site, then will release the compression, so that vacuum will be generated. Okay, this one is the right picture will be of example of hemovac drain. Okay, hemovac drain. Okay, this one is the example for your Jackson JP drain. Nothing but a Jackson Pratt drain. Okay, Jackson Pratt drain. Okay, this example for JP drain. Okay, these are the all of the example of your closed suction, closed non-suction drains. Okay, and you can see. Okay, you can see. So they asked the closed suction drains. Okay, closed suction drains. Okay, we know that. Okay, your hemovac and Jackson Pratt drains are the example for your closed suction drains. Okay, so you can see. Okay, which one is the 2 and C is the correct. Okay, 2 and 4 are the correct. So option number C is the right answer. Okay, now NG tube and Penrose tube. Penrose is a open suction. Okay, open drain. Okay, NG tube is the closed non-suction drains. So all of clear regarding the first question. So option number C is the exactly the right answer. So we'll go with the second question. Okay, from the cardiac, you can see. Okay, here we have the patient with the alcoholism. Okay, alcoholism collapse suddenly on cardiac monitor. Okay, so he'll collapse suddenly, and on cardiac monitor. Okay, shows following below cardiac arrhythmia. Okay, so what is the most likely cause and intervention? Okay, so here we're having the case of alcoholism. Okay, suddenly collapse on the road. Okay, after the what we'll do, we'll connect on the monitor. Okay, cardiac monitor, so it will show the below given cardiac arrhythmia. So what is the probable cause and intervention for the given ECG? Okay, first thing. Okay, how to identify the ECG? Okay, first one, you have to say the diagnosis. Okay, you have to say the diagnosis. Okay, which arrhythmia it is. Okay, first you have to see which arrhythmia it is. Okay, so find out the which arrhythmia it is. Okay, you can see. Okay, after that I'll read out the what is the treatment we have to do. We have to tell. Okay, first one to say. Okay, first one. Okay, option number A is rearm the patient with the rewarm the patient to correct the hypothermia. Option B is administer the magnesium sulfate to correct the hypomagnesemia. Option number C is administer the glucose to correct the hypoglycemia. Option number D is administer the naloxone to correct the opioid. Okay, narcotic overdose. Okay, option D is this one. So just see the question. Okay, and just try to answer the question. Okay, you have to choose the right answer. Okay, you have to choose the right answer. I'm waiting for your answers in the comment box. Okay, just I want everybody to be participate in the session. Okay, just try to being actively. Okay, then only it will be helpful for you also. So if that is right or not, you have to put the answer in the comment section. Okay, you can see that ECG given below. You can identify the which kind of arrhythmia and which is what is the treatment for that one. Okay, you can see. Till that you can see. Okay, so normal QT interval. Okay, you can see that this one is a normal QT interval. Okay, what is a normal QT interval? Normal QT interval will be 0.3 to the 0.40 second. Okay, so we know that. Okay, in all interval, okay, QT interval is the longest interval. Like QT interval is the longest interval. Okay, if it is QT interval is more than 0.45 second. Okay, it is more than 0.4 second. We'll call that one as prolonged QT. Okay, we call that one as prolonged QT interval. Okay, you can see. So your MgSO4. Okay, your magnesium is a cation. Okay, magnesium is inversely proportional. Okay, it is inversely proportional to the QT interval. Okay, it is inversely proportional to the QT interval. Okay, so now you can see, okay, what will happen if you just imagine, okay, if magnesium is low, okay, if magnesium is low, what will happen? Okay, there will be a increased QT interval. Okay, there is increased QT interval. Okay, we know that, okay, because it is a thumb rule, we can say, okay, we can say thumb rule. Okay, it is thumb rule in the cardiology. Okay, we know, we say that, okay, it is thumb rule in the cardiology, that is the thumb rule of cardiology, that is basics of ECG. Okay, so magnesium is inversely proportional to the QT interval. Okay, when there is a reduction in, okay, when there is reduced magnesium, there will be an increased QT interval. Okay, if it is more, okay, if when there is a magnesium toxicity, the QT interval will be short. Okay, the shortened QT interval will be there, like that. Okay, vice versa. So that is shown in the ECG also. Okay, you can see this one is a normal QT interval of interval of 0.3 second. Okay, here you can see there is a more than 0.45 second. Okay, there is a prolonged QT interval is there. Okay, so hypomagnesemia is the one of the cause for your prolonged QT interval. Okay, all of you clear regarding the QT interval? And you can see, okay, you can see the arrhythmia given here. So the which kind of arrhythmia? Normal ECG, you can see normal ECG will be P, will be having the P wave and the Q followed by Q, R, S and the T. Okay, this is a normal ECG. Okay, this is your normal ECG. But here you can see what is happened in the given question. Okay, there is no PQRST, there is the zigzag. Okay, so there is the arrhythmias are there. Okay, there is the arrhythmias are there. Okay, we call this one as, okay, QRS wave. Can you able to identify QRS wave? QRS wave. Okay, QR can see the QRS wave. P QRS. Okay, so all are different. Okay, all are different in the amplitude. Okay, so we are having the different QR intervals. Okay, we are having the different QRS wave. Okay, all QRS were different. Okay, that's why we call this one as this arrhythmia as polymorphic. Okay, we call this one as polymorphic. Okay, we call that this kind of arrhythmia as the polymorphic ventricular tachycardia. Okay, rate also higher here. So we call this one this arrhythmias. Okay, this given arrhythmia we are diagnosing as polymorphic means the morphology of the QRS wave is different. Okay, they are not similar. Okay, polymorphic, we call polymorphic VT, or another name for polymorphic VT is the torsus torsidi pointers. Okay, we call that one as torsidi pointers. Is the arrhythmias. Okay, is the arrhythmia given in the even in the ECG. Okay, normally VT there will be a monomorphic VT. Okay, there will be a same interval of, okay, PQRST wave. Okay, PQRST wave. This one is the monomorphic VT. Okay, so morphology of the QRS wave is same here. Okay, we call this one as monomorphic VT. Okay, we call this one as monomorphic VT. All of you clear regarding the monomorphic VT and polymorphic VT? This one is the monomorphic VT. Okay, we can call this one as monomorphic ventricular tachycardia. Okay, so all your QRS waves are normal. Okay, so I'm just go to the question now here. So what we will do, we know that, okay, our magnesium and the QT intervals are inversely related. Okay, so we know that, okay, in case of the like a chronic alcoholism. Okay, in case of chronic alcoholism, okay, there will be a electrolyte imbalance. Okay, there will be, of course, there will be electrolyte imbalance will be there. Okay, in that also, so we know that magnesium also very important, vital electrolyte. So if there is any hypomagnesemia, okay, so nothing but a magnesium level is reduced. Okay, so in that case, okay, it will cause the polymorphic VT. Okay, that will cause this one is nothing but a polymorphic VT. Okay, because QRST, okay, P or PQRS, QRS interval, okay, QRS wave is abnormal. Okay, all are different in size and amplitude. Okay, that's why it is a polymorphic video. Okay, so that's why first our aim is to correct the magnesium. Okay, by giving the magnesium injections. Okay, so that's option number B is the right one. Okay, so we know that, okay, here there is no any Osborn wave, here there is no epsilon wave. Okay, that's why there is a no, it's not indicating any hypothermia. Okay, so there is no need to rewarm the patient. Can you see the option number C? Glucose. If there is a reduced glucose level in body, hypoglycemia, there will be sweating. There will be sweating. There will be giddiness. There will be syncope will be there. Okay, no hypoglycemia. There is nothing like polymorphicity cannot be seen in the hypoglycemia. So option number C is eliminated. And you can see naloxone. Okay, naloxone is the antidote for your opioid toxicity. Okay, antidote for your opioid toxicity. Okay, so here there is no sign of any in ACE. There is no sign of any opioid toxicity. Okay, so there is no option D also. We can easily eliminate. Okay, just it is like we know we should know some special kind of ECG here. We can see okay this are all called special ECG. Okay, Osborne wave nothing but the like upstroke. Okay, there is a one extra wave. Okay, an extra wave it just came into the this one is a P wave. Okay, QR in the R wave only one extra will come before the T wave. Okay, we call this one as the Osborne wave. Okay, we call this one as or this one is considered to be a Osborne wave. Okay, this can be seen in case of hypothermia and hypercalcemia. We can have a Osborne wave visible. Okay, and I can see third one. Second one, okay, that is your epsilon wave. Okay, this is your epsilon wave. Okay, I'm teaching you this all are the considered as special ECG. Okay, special abnormal ECG. Okay, special abnormal ECG. Okay, and you can see epsilon wave. Okay, so you can see epsilon wave in the ARVD case. Okay, in the ARVD case, you can see. Okay, there is submerged. Okay, there is submerged a small epsilon wave in the S wave. Okay, this one is P Q R S. Okay, in R wave only one small wave will be obscured. Okay, will be obscured. Okay, we call this one as the epsilon wave. Okay, in case of ARVD, we can see the epsilon wave. Okay, so ARVD nothing but the arrhythmogenic right ventricular dysplasia. Okay, right ventricular dysplasia. That is your ARVD. Okay, and a delta wave. Okay, delta wave nothing but the when P wave is zero after P wave. Okay, normally you should have a QRST complex. Okay, but here what will happen after P wave? Okay, there is sudden there is upstroke in the R wave. Okay, after that okay S and then T. Okay, this upstroke is called as delta wave. Okay, upstroke is called as there is upstroke in the R wave. Okay, we call this one as the delta wave. Okay, in WPW syndrome. Okay, Wolf Parkinson's White syndrome. We can have a river delta waves. Okay, so regarding ECG and other special kind of ECG changes, we can see now we'll further proceed with the third question. Okay, third question of the session. Here we having the which of the following is the cause of hyperkalemia in the child? Okay, so what is the cause? Option A is hypomagnesemia. Option B is metabolic acidosis. Option number C is hypophosphatemia. Option number D is hypoparathyroidism. Okay, you can see just try to put your answer in the comment section. I'm waiting for your answer right now here. Why I'm telling you, why I'm forcing you to answer because I want everybody to be interested. Okay, if you're having bored, okay, you're feeling sleepy, if you're putting the message, okay, you'll be active in the session. Okay, so that's why I'm requesting you to be active in the session. Okay. Here you can see, okay, so normally considered, okay, this one is a cell, okay, this one is a cell. So what will happen, okay, inside the cell, okay, in case of acidosis, okay, in case of acidosis, what will happen? There will be a extracellular H plus ion will be more, okay, H plus ion, extra cell, okay, this one is the cell. So extracellularly H plus ion will be more, okay. If H plus ion is more, the pH will be reduced, okay. So we can say you can write, okay, if H plus ion and pH are inversely related, okay, they are inversely related. Okay, if H plus ion is more, the pH will if H plus ion is more, the pH will reduce. Okay, the pH will be reduced. Mm. So here is what is happening. Okay, okay, inside the cell. Okay, outside the cell there is H plus ion is more because of acidosis. Okay, because of acidosis. Okay, so sorry. Okay, so what will happen? Okay, normally inside the cell, okay, potassium will be more. Okay, potassium will be more. That is your normal scenario. Okay, this one is your no in a normal person. Okay, normal person. Okay, like this will be there. Okay, where potassium will be we call okay potassium as the bag of the potassium. Okay, bag of the potassium. Okay, that is your cell. Okay, cell is nothing but the bag of potassium. Okay, that is in a normal scenario. So in a hyperkalemia, what will happen? Okay, we'll see in hyperkalemia. So in a hyperkalemia, okay, in hyperkalemia, what will happen? As a body compensation mechanism, okay, as a body in a hyperkalemia. Okay, hyperkalemia nothing but your potassium value is more than 5 milliequivalents per liter is the hyperkalemia. Okay, this consider this one is a cell. Okay, this one is a cell. So this one, okay, here we are having more potassium here. Okay, here there is more potassium here because of hyperkalemia. So what will happen? Inside H plus ion will be there. So there will be exchange of the potassium. Okay, the potassium will go inside the cell and H plus ion will come outside the cell. Okay, H plus ion will come outside the cell. So what will cause? Okay, I told you H plus ion and the and your pH are inversely related. Okay, your pH are inversely related. Like if H plus ion is increasing more, what will happen? There will be a metabolic acidosis. Okay, there will be a metabolic acidosis will be there. Okay, there will be a metabolic acidosis will be there. Okay. So that is the hyperkalemia. Okay, can be seen in case of, I told you, it can be seen in case of metabolic acidosis. Okay, metabolic acidosis, you can have the hyperkalemia. Okay, as the compensatory mechanism. Okay, okay, this is regarding the hyperkalemia compensatory mechanism of the body. Okay, a body will try to body compensation. Okay, body will try to compensate for the hyperkalemia by pushing down the H plus from inside the cell to the outside the cell. Okay, and potassium outside the cell to the inside the cell. Okay, that is main basic, okay, compensatory mechanism of our own body. Okay, God has given all our compensatory mechanism for any abnormality in the body. Okay, all of clear regarding the third question. Then we'll move towards the again. Okay, fourth question of the session. So fourth question you can see, okay. So what is the compression and ventilation ratio in the post-puberty onset of the cardiac arrest if two rescues are present? Okay, option A is 15 30 raised to 2, 15 raised to 1. Option number D is 30 raised to 1. Okay, you can see. So normally what happen? Okay, so according to the your American Heart Association guidelines, okay, according to the AHA guidelines, okay, so they divide the compression and the ventilation, okay, based on the puberty. Okay, pre-puberty and post-puberty. Okay, and post-pubertal age. Okay, for pre-puberty, okay, for I'm talking about the now pre-pubertal age. For a pre-pubertal age people, okay, so again we'll divide into the single rescuer and the double rescuer. Okay, single rescuer. Okay, single rescuer and the there is any two rescuer are there. Okay, in a single rescuer, okay, the compression ventilation ratio will be 30 raised to 2. If the compression, okay, if the two rescuers are there available, we can reduce the compression and we can increase the ventilation because in a children's, okay, in a children, they require the more respiration, okay, in them. So their respiratory rate will be more. Okay, that is regarding the pre-pubertal age. Okay, and you can see now regarding the post-pubertal age, okay, for a post-pubertal age, for a post puberty, okay, for a post puberty is nothing but adults. Okay, for adolescents, okay, for adolescents, okay, so the compression and ratio, ventilation ratio will be always 30 raised to 2 only. Okay, along with the single rescuer. Okay, along with the single rescuer and the double rescuer. Okay, the ratio will be same only because adults requires, okay, only compression. Okay, hand and compression is very important in the adults. Okay, in the adults, okay, hands and compression is very important. Okay, that's why we are focusing on the compression. Okay, so that's like that only. Okay, so we have to increase the compression rate. Okay, so that you can see here we're having the post puberty onset of the cardiac arrest. So that will be 30 raised to 2 only. Okay, there is no change in the ventilation and compression ratio. Okay, you can see the like a characters. Okay, we'll see now regarding the what are the characteristics of high quality CPR. Okay, high quality CPR. Okay, to say high quality CPR. Okay, in notes now we'll write. So we started with the according to the ACLS. Okay, according to the ACLS. Okay, according to the ACLS. Okay, what are the criteria to say high quality CPR? Okay, so we are initiated the CPR. Okay, according to the ACLS guidelines. Okay, to say that one we have to do a high quality CPR. Okay, nothing but the first one. Okay, push hard. Okay, first word is the push hard means we have to put the compression. Okay, compression of 2 inches. Okay, the compression should be the chest wall should go inside by the 2 inch. Okay, by the 2 inch or we can say 4 to 6 centimeter. Okay, the chest wall should compress up to 2 inches or 4 to 6 centimeter. Okay, or else we can say it should, okay, our chest wall should go one third AP diameter of your chest wall. Okay, so one third of the AP diameter of chest wall should go inside. Okay, that's how our compression should be. Okay, so push hard. Okay, that is the push hard. Okay, then push fast. Okay, so to say high quality CPR, okay, we should have a criteria. So, okay, push hard, I told, and push faster. Okay, we have to push faster. So we have to focus on pushing hard and pushing faster. Okay, pushing faster, nothing but the like for every okay every minute. Okay, we have to focus on compression of 100 to 120 compression. You can see 100 to 120 compression per minute. Okay, per minute. Okay, we have to focus on 100 to 120 compression should be given in the minute. Okay, push hard and push faster. Okay, that is the main one of the criteria to say high quality CPR. And then we have to allow. Okay, we have to allow for the allow to chest. Okay, allow the chest to recoil. Okay, we should ensure that. Okay, we should make sure that. Okay, we should make sure and we should ensure that the chest wall should be adequately recoiled. Okay, then only the blood will come to the heart. Then only we can able to eject the blood out of the heart. Okay, that's why we have to allow the chest to recoil. Okay, and then we have to minimize the interruption. Okay, we have to minimize the interruption. Okay, we have to minimize the interruption less than, okay, less than 10 second. Okay, we have to minimize the intervention. Okay, interruption less than 10 second. Okay, so when two rescuer are there, we have to change. Okay, we have to change the position. Okay, during that time, okay, we should focus. Okay, the interruption period should be less than 10 second. Okay, and okay, we have to, okay, for every 2 minute. Okay, in case of two rescuer. Okay, for every 2 minute. Okay, for every 2 minutes, we should change the roles. Okay, we should change the roles. Okay, that's regarding that is one of the main component of your criteria to say high quality CPR. Okay, then that's regarding, okay, this push hard, push fast, and the allowing the allowing the just to recoil. Okay, and then to say if advanced. Okay, if there is any advanced. Okay, if there is any advanced airway is there. Okay, if there is already patient is intubated. Okay, already person in having LMA, that time what we can do, for every 2 to 3 second. Okay, we have to give a one breath. Okay, we have to give a one breath to the ambo or through the chief. Okay, that's regarding the ventilation part. Okay, normal compression, I told you 15 raised to 2. Okay, 15 raised to 2 in a two rescuer. Okay, two rescuer, but two in a pre-pubertal age. Okay, pubertal age. Okay, pubertal age. Okay, rest all remaining all. Okay, remaining any one rescuer, two rescuer. Okay, all case we have to give a 30 raised to 2 compression. Okay, that is the main ratio. Okay, you can see again here one more time. Advanced airway is there. Okay, we have to give a every 2 to 3 seconds we have to give a one breath. Okay, I told you compression and the ventilation ratios. So we can tell, I told you I have to change the compression and ventilation. Okay, for every 3 minutes. Okay, and we have to allow the minimize the interruption to less than 10 seconds. Okay, this all are the like a quality point. Okay, quality point to say high quality CPR. Okay, then we'll go with the fifth question. Okay, here we're having the fifth question. So here we're having the 6-month-old infant in the emergency department. Okay, requires the rapid sequence intubation. Okay, we call this one as the RSI. Okay, what do you mean by RSI? A rapid sequence intubation. Okay, for a severe respiratory failure. Okay, then the physician orders prepare the atropine and suctional choline. Okay, so what is the main purpose of keeping the atropine bedside during the rapid sequence intubation? Okay, option A is to prevent the fasciculation caused by succinyl choline. Option number B, to reduce the risk of bradycardia from the vagal stimulation. Option number C is to reduce the oral secretion. Option number D is to treat the ventricular tachycardia. Okay, these all are the options right now here. Just you can choose the right answer in the comment box. Okay, just try to put the message. Okay, I'm waiting for the question, your answers right now. Let me, okay, first of all, let me tell you regarding the RSI. Okay, it's very interesting. Okay, it's very interesting topic. Okay, to know regarding the RSI. Okay, rapid sequence intubation. Okay, if you're working in the casualty, okay, if you're working in the OTs, you'll be knowing regarding the rapid sequence intubation. Okay, it's apart from the routine intubation. Okay, it is very different from the your normal routine intubation. Okay, here what we are doing, here we are okay. Main purpose of RSI, okay, rapid sequence intubation, to prevent the aspiration. Okay, so we know that okay, patient will be suddenly coming to the casualty. Okay, they will be having the respiratory compromise. Okay, they will be collapsed. Okay, they will be unconscious. Okay, that time they will be having the prone to have a aspiration. Okay, prone to have a aspiration. Okay, that's why we want to prevent the aspiration and we have to protect the airway. Okay, for that way only we are intubating with the endotracheal tube to seal the trachea and to prevent the aspiration. Okay, that's what we call as a rapid. Main purpose of the rapid sequence intubation is prevention of aspiration. Okay, and reducing the apnea period. Okay, apnea period, we can say apnea period we are reducing less than 40 seconds. Okay, 40 seconds means here we are not doing the less than 40. We here we are not focusing on the pre-oxidation part. Okay, more than like 2 minutes. Okay, more than 3 minutes and all. That's why we are reducing the apnea period. Okay, normally apnea period will be 2 to 5 minutes. Okay, but for here for a rapid sequence intubation, okay, we only less than 40 seconds. We have to place the endotracheal tube into the trachea after disconnecting from the oxygen source. Okay, that's your apnea period. Okay, so here we are reducing the apnea period. Okay, and next one, third one, we are giving the ultra. Okay, we're giving the faster acting. Okay, we are giving the faster acting muscle relaxant here. Okay, so we are giving the faster acting muscle relaxant like succinylcholine. Okay, or succinylcholine along with what? Okay, rocarinum. Okay, rocarinum. Both are considered to be a faster acting muscle relaxant. Okay, so that is the main basic difference of your rapid signal intubation and your normal routine intubation. Okay, so that's why I told you. Okay, so during intubation, what will happen? Okay, intubation, what will happen? Okay, the laryngoscope they will put, and then after that they will do a we'll put a endotracheal tube. Okay, so what will happen during that time? Okay, there is a high risk to have a vagal bradycardia. Okay, vagal stimulation will be there. So that's why vagal bradycardia will be there. Okay, to reduce the bradycardia risk, okay, we have to tell the nursing staff who is seeing the who is assigning for patient. Okay, we will tell them to keep a atropine ready. Okay, that is also one of this one, and to reduce the secretion also we can use the atropine. Okay, so option number B is the right answer. Okay, option number B is the right answer here. Okay. This all okay. During like everyone knows that okay, regarding the like rapid synchronous intubation, there is high risk to have a vagal bradycardia. Okay, so that's why. So even your succinyl colon. Okay, even your succinyl Succinylcholine will cause the vagal bradycardia. It will cause the vagal bradycardia. Okay, that's why we have to keep ready with the tropin bedside. Okay, 0.6 mg. Okay, recommended dose for vagal bradycardia is 0.6 mg of atropine. Okay, atropine. Okay, where atropine can be given. Okay, where atropine can be given as the IM also we can give, IV also give. Okay, it's in case of symptomatic bradycardia, we'll go with the IV atropine. And six questions from the community. Okay, here we are having which of the following strategies not encouraged by UNICEF under the GOBI program? Okay, GOBI campaign. Okay, option A is growth monitoring. Okay, growth chart to monitor the child development. Option B is oral rehydration therapy to treat the dehydration. Option C is better and continuous evaluation of the children to the 5 years of age. Option D is immunization against the major childhood diseases. Okay, so which one is the not a part of your GOBI campaign? Okay, so it's a direct question. Okay, you can choose the right answer right now here. If you see the GOBI strategy, okay, it's developed by especially by the UNICEF and the two organization. Okay, two very very important organization of the India, that is your UNICEF and the WHO. Okay, both are given the GOBI strategy. Okay, go for again we are extended to the GOBI triple F strategy. Okay, see G for growth monitoring with the growth chart. Okay, I'm right down here, so it'll be very like effective for you. You can see I'll write down. Okay, all GOBI triple F. Okay, here you can see G for growth monitoring. Okay, how we can monitor the growth? Okay, how we can monitor the growth? So we know that okay in India, growth delay is very common problem. So how we can growth monitor? Okay, by the growth chart. Okay, we are having the growth chart. Okay, by the like David Sackett has produced the like growth chart are there. By seeing the growth chart, we can monitor the growth. Okay, so then O for ORS. Okay, O for oral rehydration therapy for dehydration. Okay, we know that okay in India most common, okay, one of the most common cause for your unconfirmed mortality rate, that is your diarrhea and dehydration. Okay, so to treat the dehydration, we have to give ORS. Okay, and then breastfeeding. Okay, so we know that, okay, in India it's difficult to initiate the breastfeed as soon as possible. Okay, so we have to focus on the breastfeeding to prevent again, okay, to give the major nutrition to the children, okay, to protect against the so many infections. Okay, so we have to encourage on the breastfeeding also. Okay, and I for the immunization. Okay, so vaccine preventable disease. Okay, I will tell you regarding the seven vaccine preventable disease. Okay, so for all VPDs prevention. Okay, vaccine preventable disease. Okay, so we have to focus on the we are encouraging on vaccination part. Okay, vaccination part, vaccination preventable PPD is nothing but a vaccination preventable diseases. Okay, so immunization to prevent against a major childhood illness. Okay, so that is a GOBI strategy. Okay, and we are extended. Okay, we are extending the GOBI to the GOBI triple F. Okay, one F is for family planning. Okay, we are focusing on the family planning. Oh, okay, family planning by using the appropriate contraceptives. Okay, how we can achieve the family planning by using the appropriate contraceptives. Okay, we have to use the appropriate contraceptives. Okay, this one is for healthy child. Okay, this one is for healthy, we can say healthy spacing. Okay, healthy spacing for children to grow. Okay, if there is adequate space between the first child and second child, the first child can be taken care of very healthily. Okay, that's main focus of family planning. Okay, for healthy spacing. Okay, next one is for female literacy. Okay, female literacy. Next one is for female literacy. Means, okay, if the female is educated, okay, if the female is educated, okay, if the pregnant woman is educated female, we can say educated female can have a equipped care. Okay, she can give a well care to the equipped care we can give to the babies. Okay, that's why we have to increase the female literacy rate. Okay, and then another F for the food supplementation. Okay, food supplementation for whom we have to focus on the food supplementation for pregnant mother. Okay, pregnant mother on the young child. Okay, and the young children. Okay, if both we have to give a food supplementations. Okay, that's regarding the Rubeles Gobi strategy. Okay, now we'll go back to the question. So you can see option number C is the not a part of the Gobi campaign. Your better and continuous evaluation children's is not a part of your Gobi campaign. Okay, so option number C is the right answer right now. You okay? All of you getting okay? This one is from Mason. Okay, and see question number 7. Okay, treatment of choice. Okay, treatment of first choice in the acute gout. Okay, acute gout. Okay, what will happen in acute gout? Okay, there will be increased uric acid production. Okay, there will be increased uric acid production, or two may be the cause. Okay, two may be the cause for increased uric acid. That may be the increased production or reduced excretion. Okay, increased production, or we can say increased production or reduced excretion. Okay, reduced excretion. Okay, both will lead to the increased uric acid in the body. We know that, okay, uric acid is produced by the breakdown product of your purines and the pyrimidines. Okay, so in that case, okay, there will be more production. Okay, if there is any problem with the kidney will not eliminate. Okay, kidney will not eliminate the uric acid. So what will happen? There will be a build-up in the uric acid in the body. So that will deposit into the tissues. Okay, into the bones. It will cause the severe pain in the all individuals. Okay. So what is the first choice of treatment for acute gout? They're asking here. Okay, option number A is oral coclichin. Option B is oral methotrexate. Option C is allopurinol. Option number D is sulfasalazine. Okay. So our main focus is to, okay, in acute gout. Okay, in acute gout, what is the main problem? So in acute gout, what is the main problem here right now in acute gout? I told you there will be a deposition of the uric acid into the tissue, into the bones. Okay, so our main goal. Okay, so here what is the problem in acute gout? There will be a severe pain will be there. Okay, severe pain and severe inflammation. Okay, two will be there. Okay, severe pain and the severe inflammation will be there. Okay, our target. Okay, so in acute gout, okay, what is our target? So now the patient is there with you, the acute gate. So what is the target? Okay, what is the in acute gate? Okay, what is the target? acute gout. Okay, what is our target of treatment? Okay, in acute gout, what is the target treatment? Targeted treatment. Okay, target treatment in acute gout. Main our focus is to reduce the pain. Okay, reduce the pain and reduce the inflammation. Okay, and reduce the inflammation. Okay, two are the main goal. Okay, to reduce the inflammation is the that is the two target of the treatment in the acute gout. Okay, so we'll give the anti-inflammatory drugs. Okay, we'll give a anti-inflammatory drugs like, okay, anti-inflammatory like drugs like corticosteroids. Okay, we'll use the corticosteroids and the corticosteroids and anti-inflammatory drugs like your coquelicin. Okay, coquelicin is considered to be a anti-inflammatory anti-inflammatory drugs. Okay, this is the main goal of treatment, and for pain we'll give a non-steroidal anti-inflammatory drugs. Okay, you can see now. So we'll see now we'll go back and we'll see the options right now here. So oral coquelicin is the right answer. Okay, so it is an anti-inflammatory drug. That's will give a oral coquelicin drugs. Okay, you can see another treatment. Okay, so I told you an acute gout. Okay, our NSAID is to reduce the pain, coquelicin and glucocorticoids. Okay, our methylprednisolone and the hydrocortisone. Okay, that is the mainstay of treatment in the acute gout. Okay, we want to reduce the pain and we want to reduce the inflammation. Okay, in chronic gout. Okay, in chronic gout, what will happen? Our treatment goal will be different. Okay, so we focus on the so how, okay, uric acid produced by the uric acid, okay, uric acid is produced by the enzyme called as xanthine, okay, your uric acid main produced by the your uric acid, okay, your uric acid is mainly produced by the enzyme called as uric acid produced by the enzyme called as xanthine oxidase, okay, xanthine oxidase. Okay, xanthine oxidase. Okay, so our main goal of treatment is to prevent. Okay, is to destroy the xanthine oxidase. Okay, that has been done by your febuoxstat and allopurinol. Okay, both will do the reduce in the of uric acid. Okay, by inhibiting the enzymes called as xanthine oxidase. Okay, they will inhibit the xanthine oxidase. Okay, and to increase the excretion. Okay, we can use the propionic acid and the sulfur pyrazine. Okay, the drug that will increase the excretion of the uric acid from the body. Okay, that is the main goal of treatment in the acute gout case. Okay, now we'll go with the eighth question of the session. Okay, eighth question here right in front of you present. Okay, you can see the question right now. So here, okay, here we're having a 45-year male, okay, came to the emergency unit, okay, with the RTA after massive blood loss, okay, and the patient has been initially resuscitated with the crystalloids, so crystalloid nothing but the your NS, okay, NS or the RL, okay, so which is the best indicator, okay, best indicator of resuscitation in the shock, okay, so option A is central venous pressure CVP, option B is urine output, option C is the stroke volume variation SVV. Option D is the pulse pressure variation. Okay, that's all of the options right now here. Okay, don't be confused. Okay, then you try to put the appropriate, okay, or right answer in the comment box. Okay, I'm waiting for your answer right now here. So whether it is option A, option B, whatever it may be, you just try to put your answer. Okay, don't hesitate to put the answer in the comment box. Okay. So now we can see, okay, so fluid, okay, so if you want to give the normally shock is happened, okay, normally in hypovolemia, what will happen, okay, there will be shock, okay, there will be shock means we have to give a fluids, okay, we have to give a fluids, okay, that may be the crystalloids or the colloids, okay, we may give the crystalloids or colloids, okay, to give the to determine, okay, to determine the how much to give, okay, to determine the fluid needed, okay, how much fluid is needed, okay, so we want to know how much fluid is needed. Okay, how we can check? Okay, based on the inferior vena cava collapsibility index. Okay, IVC index. Okay, we can see or we can see the central venous pressure. Okay, we can see the central venous pressure. We can see the stroke volume variation. We can see the pulse pressure variation. Okay, what do you mean by pulse pressure variation? Nothing but the or like from the systolic BP, if we're minusing the diastolic BP, we call that one as the pulse pressure. Okay, if there is a large pulse pressure is there. Okay, so you can see So two terms are there. Okay, SVV nothing but a stroke volume variation. Okay, normally stroke volume will be 70. Okay, if one now stroke volume is 50. Again, okay, next minute, okay, the stroke volume is a 50. So what is the normal? Okay, normally your stroke volume variation that is around 20 mmHg. Okay, 20 mmHg. Okay, if the stroke volume variation is more than 12, we call this one as a fluid deficit. Okay, there will be a fluid deficit. Okay, so that time what we'll do? We'll give a bolus fluids. Okay, we'll give a bolus fluid to correct the stroke volume variation. Okay, and next one is the pulse pressure variation. Okay, pulse pressure variation means nothing but the SBP minus systolic blood pressure minus diastolic blood pressure. Okay, it should be normal between the range of 50 to 30. Okay, 30 is the normal pulse pressure variation. Okay, if it is less than 30, we call this one as narrow pulse pressure. Okay, if it is more than 50, we call this one as widened. Okay, we call this one as widened pulse pressure. Okay, that is main regarding the pulse pressure variation. Okay, this one is to determine the how much fluid. Okay, whether the if person is going for the broader, okay, narrow pulse pressure, we have to give the patient with the fluid. Okay, so to give the fluid, okay, determine the fluid, okay, to determine the how much fluid is required, okay, how much fluid is determine the fluid requirement. We'll use the central venous pressure, we'll use the stroke volume variation, we'll use the pulse pressure variation, okay, but not the urine output. Okay, urine output is the it's considered as the best indicator. Okay, now okay, we don't want to determine the how much fluid. Okay, we know that okay, already there is a massive blood loss is there. We given the crystalloid fluid. Okay, we given the up 2 liters of fluid we given, and after that, okay, we want to know whether the patient is successfully revived by the shock or not. Okay, so your urine output. Okay, if the person is pouring more or equal to the 0.5 ml per kg per hour. Okay, per hour is urine is there. Okay, we can consider okay, it is normal. We have been okay successfully resuscitated a patient from the shock. Okay, so we not put is the right answer. Okay, then we'll go with the ninth question here. So here we're having the 65-year-old male presented to the casualty with a self fall from the height. On examination, okay, find patient is having the BP of 88 by 36 mm of Hg, heart rate around 45 beats per minute. Okay, and extremities are warm and dry. Based on the clinical feature, identify the which type of shock it is. Okay, it is a NORCET. Okay, it's your NORCET 9 question. Okay, they ask it regarding the type of the shock. Okay, in last NORCET. Okay, we may expect the another question from this NORCET also, NORCET 10 also. So options are right now here. Okay, option A is the cardiogenic shock. Option B is a neurogenic shock. Option D is the distributive shock. Option C is the distributive shock. Option D is obstructive shock. Okay, these all are the type of the shock. Okay, so based on the clinical feature, you have to identify the which type of shock it is. Okay, just see the question. Okay, analyze the answers. Okay, I'm waiting for your answers in the comment box. Okay, just everyone just try to put your answer in the comment box. Okay, if you're getting the class. Okay, if there is any problem, you just like put a proper message in the comment box. Okay, I'll modify the class. Okay, I'll customize the all classes for you. Okay, to see especially, okay, to see especially like a shock types. Okay, to show you see the shock types. So exactly what in the shock? Okay, shock in what will happen in a shock? A body, okay, a body tissue will not be a body. Okay, a body will not get the enough blood. Okay, body tissue or the vital organs. Okay, body tissues and the vital organs. Okay, vital organs will not have a enough blood. Okay, will not have a enough blood will not be getting. Okay, so if body tissues are not getting blood, what will happen? There is increased lactate in the tissues because anaerobic mechanism, and there is a increased tissue toxins. Okay, there is increased tissue toxins level. Okay, your cells start to die. Okay, that's why it will produce the toxins. Okay, that is the main problem will happen in the shock. Okay, in the shock there are different type of shocks are there. Okay, so we'll see the all different type of shocks. Okay, so first one to say that is your hypovolemic shock. Okay, we call this one as the hypovolemic shock. Okay, hypovolemic shock, what will happen? So in hypovolemic shock, okay, what will happen? There is a increased, okay, blood volume loss. Okay, we can say there is the blood volume loss. Okay, it may be a fluid, it may be a blood components. Okay, so here what will happen? Okay, here normally heart rate will be more. Okay, so as a sympathetic nerve system activated, your heart rate will be more. Okay, and your BP will be reduced. And if you see the peripheries, okay, if you see the examine the peripheries will be cold and dry. Okay, cold and wet will be there. Okay, it will be cold and wet. Okay, that is your hypovolemic shock. Okay, and then coming for the cardiogenic shock. Cardiogenic shock. Okay, so here what will happen normally? Your heart will fail. Okay, your normal left ventricular contractility. Okay, your left ventricular contractility is reduced. Okay, reduced. So what will happen here? Okay, so that's why BP will be less. Okay, again BP will be less, and heart rate will be more. BP is as a sympathetic nervous system activated. BP will be less, and heart rate will be more. And peripheries. Okay, and peripheries will be cold and wet. Okay, here in cardiogenic shock. Okay, so mainly MI is the most common cause. Okay, your myocardial infarction is the most common cause of your cardiogenic shock. Okay, that's regarding cardiogenic shock. Okay, next one to say third one, that is your anaphylactic shock. Okay, anaphylactic shock. Okay, here this one is especially we call this one as allergic reaction. Okay, so what will happen? Okay, so in case of allergy, okay, any allergy, okay, any allergies, okay, any allergies. So what will happen? Okay, there is increase the production of immunoglobulin E. Okay, so immunoglobulin E, what will happen? There will be a increased tissue permeability. Okay, so there will be a vasodilation. Okay, we can say there is a severe vasodilatation will be there. Okay, so vasodilation nothing but the reduce. Okay, increased heart rate. Okay, so increased heart rate and reduced BP will be there. Okay, or a vascular volume will be distributed into the third space. Okay, so here that's why we'll give a vasopressor as the drug of choice. Okay, your vasopressor, your noradrenaline, adrenaline as the drug of choice for the anaphylactic shock. Okay, and fourth one to say that is your like a distributed shock. Okay, so one of the example for your distributed shock is your anaphylactic shock. Okay, here what will happen? Okay, the due to the vasoplasia. Okay, due to the vasoplasia, nothing but a blood vessels dilatation. Okay, nothing but a blood vessel vasopressin nothing but a blood vessel dilatation. Okay, so whole volume. Okay, so blood vessel will be dilated. Okay, so that's why what will happen, the blood volume, whole volume will be divided into the distributed into the third space, into the tissue. That's why in the intravascular space blood volume will be very less. Okay, very less. Okay, all blood volume will be distributed into the tissue. That's what we call as a distributive shock. Okay, and the fourth one, okay, and fifth type of shock is that is your fourth one is over. Okay, fifth one is your neurogenic shock. Okay, neurogenic shock. Okay, normally what will happen? Okay, normally what will happen? Your all sympathetic nervous system. Okay, all your sympathetic nervous system and the parasympathetic nervous system. Okay, they will be carried out to the spinal tract. Okay, if there is any damage, okay, any damage or any trauma to the any damage, okay, any fracture or any trauma to the trauma above the T6 level. Okay, above the T6 level. Okay, above the T6 vertebra. So above the T6 vertebra only there will be a supply with the sympathetic nerve system. Okay, so there will be damage to the sympathetic nerves. Okay, there will be damage to the sympathetic nerve. Okay, that's why there will be a no sympathetic tone. Okay, that's why there will be blood vessels will be dilated. Person will be having the hypotension and the shock will be there. Okay. So, but here, okay, due to the sympathetic nervous system is not working properly, the heart rate will be. This is the only shock. Okay, this is the only type of shock where heart rate will be reduced. Okay, where BP will be reduced, Okay, and along with that one, okay, they will see peripheries will be dry. Okay, peripheries will be dry, and the peripheries will be. You can see peripheries will be warm and dry. Okay, warm and dry. You can see peripheries will be warm and the warm and dry will be there. Okay, that is the main. Okay, one of the unique type of shock. Okay, among the all of them. And okay, coming for the last one. Okay, last type of shock, that is your obstructive shock. Okay, obstructive shock. That means there is some obstruction for the blood flow here. Okay, there is a obstruction of blood flow from the ventricles. Okay, there may be a HOCM. Okay, hypotropic obstructive cardiomyopathy or pulmonary embolism. Okay, or pulmonary embolism is there. Okay, this all are considered to be a obstructive shock. Okay, there is obstruction for blood flow. We can say there is a obstruction for the blood flow will be there. Okay, for the blood flow will be there. Okay, this all are the different type of shock. Now we can go and see the options right now here. So option number B is the right one. Okay, I told you heart rate is reduced. Okay, heart rate is reduced, of course, and BP is reduced. Okay, and BP is reduced, and you can see warm and dry extremities. Okay, this all are the cardinal feature of neurogenic shock. Okay, means there is a fracture. Okay, after the cell fall, what will happen? Your thoracic vertebra. Okay, above T6 level is damaged. Okay, above T6 level is damaged. That's why the person is having the loss of sympathetic tone. So there is a loss of blood pressure. Okay, so that's all of the feature of your even neurogenic shock. Okay, now going with the 10th question. So here we're having the like 10, okay, here in the patient admitted in the SICU after the post laparotomy surgery and presently having the dyspnea and restlessness. Okay, so for that one, they taken an EBG, okay, to find the cause of for the complaints. Okay, based on the given EBG, identify the diagnosis. Okay, they given a pH of 7.12 and they given a PCO2 of PCO2 of 50 mmHg and bicarbonate of 36 mmHg. Okay, option A is respiratory acidosis with metabolic compensation. Option B is metabolic acidosis with the respiratory compensation. Option C is respiratory alkalosis with the metabolic compensation. Option D is alkalosis. Okay, metabolic alkalosis with the respiratory compensation. Okay, now we can see. So solving EBG, okay, solving EBG and along with the compensation you can see, okay, so always on EBG, okay, you can see a Rome criteria, okay, what do you mean by Rome? Rome nothing but a respiratory opposite and metabolic equal, okay, means pH, okay, and pH and your bicarb, okay, sorry, your PCO2, okay, your PCO2 is inversely proportional here, okay, so you can see, okay, here they given a pH of 7.12, okay, 7.12 is a pH they given, so you can see here, okay, they given a pH of 7.12. Okay, so it is indicative of acidosis. Okay, what is the primary diagnosis? Okay, primary diagnosis is acidosis. Okay, primary diagnosis is acidosis. And PCO2 you can see PCO2 is 50 mmHg. Okay, 50 mm of Hg. Okay, normally it will be 35 to 45 mm of Hg. So it is increased. Okay, so it is increased. Okay, so your PCO2 is increasing and pH is reducing. So it indicates of respiratory. Okay, for primary diagnosis is respiratory acidosis. Okay, so primary diagnosis is respiratory acidosis is the primary diagnosis. Okay, now we'll go with the secondary diagnosis. Okay, now we'll do a secondary diagnosis of the given ABG. Okay, so what is the normal bicarbonate they given? Normally bicarbonate they given around 30. You can see the question. Okay, so that is your 36. Okay, 36 is the given by 36 milli equivalents per liter is the given bicarbonate value. So what is the normal bicarbonate value? It is around 22 to 28 milli equivalents per liter. Okay, so it is now it is increased. Okay, bicarbonate is increased bicarbonate. Okay, so there is a compensation. Okay, there is a metabolic. We can say there is the metabolic compensation. Okay, so your lungs, your kidney is getting compensated. Okay, means it is getting stored. Okay, it is reabsorbing the bicarbonate from the renal table. Okay, you can see the right now you can both you can club. Okay, respiratory acidosis with the respiratory acidosis with the metabolic compensation is the right answer. Okay, primary and secondary diagnosis. Okay, so you can see respiratory acidosis with the metabolic compensation is the right answer. Okay, this one is a like a 10th question. Okay, last question of the session. Okay, thank you all for watching it. Keep on learning, keep on studying with the KNO class. Okay.